event today on models for health equity and COVID-19 vaccine distribution. My name is Michelle Calvo. I'm a program officer at the New York Academy of Medicine, and I'll be facilitating today's webinar. We hope that everyone's going to walk away today with some really practical lessons learned and strategies for effective and equitable community distribution of the vaccine. First, I'm just going to go through some housekeeping before we jump into the content. So for today's webinar, given the volume of attendees, we're going to keep everyone muted and we'll take written questions. Please feel free to enter questions as they come up in the Q&A box in the middle of the bottom bar on the screen. You can see here on the screen where that is. So just click there, type your question, hit enter. We'll address your questions either live during the Q&A or share a written response. And if we're not able to get your question answered during the webinar, we'll be sure to follow up after. And it would be helpful if you can please try to keep the questions in the Q&A box and not the chat so that we don't lose track of those. Please also know that you can enable closed captioning today. So you'll need to select the icon at the bottom bar of the screen all the way to the right that says CC Live Caption. You can turn it off also by clicking again on that icon. And if anyone's having any technical issues today, you can enter in the chat to my colleague Kana Tataishi, and she'll be glad to assist you. I'll just briefly review the agenda for today. I'm just going to talk for a few more minutes to give a brief introduction, and then we'll hear from Molly Chidester, Chief Operating Officer of Stop the Spread, who will introduce their partnership model that they've developed. Next, we'll hear from David Gross, who's General Counsel at Community Healthcare Network, about models of vaccine distribution. Emma Smith, Partnerships and Strategic Initiatives Lead at Stop the Spread, will discuss the Vaccine Plus model that they've developed to optimize vaccine appointments for connection to other healthcare and social services. And then Molly will come back on to walk us through the playbook for community-based vaccinations, which is a really fantastic, usable resource for implementing these models. And then finally, I'll be back to facilitate Q&A and discussion for the last about 15 minutes. So just want to say a few words about the New York Academy of Medicine for those who are unaware. NYAM's vision is that everyone has the opportunity to live a healthy life, and our mission is to drive progress towards improved health through attaining health equity. We are located in East Harlem in New York City and have been working to improve the public's health since 1847. And then I want to very briefly provide an overview and a preview of sorts of the overarching COVID-19 Vaccine Equity Action Collaborative through which we're offering today's webinar. We are an initiative funded by the New York Community Trust that aims to bridge community with health systems and government leaders in the New York metro region to advance vaccine equity through technical assistance and convening. We have a 20+ member steering committee of community and faith-based government and health system leaders in the 5 boroughs, Westchester and Long Island. And we're launching today a series of technical assistance activities aimed at community and faith-based groups to really build capacity to advance vaccine equity in communities across the New York City metro region through improved access, education, and distribution. And soon we'll be launching within the next few weeks a newsletter with targeted and curated data, resources, funding opportunities that are relevant to community and faith-based organizations in our region, and also building out other technical assistance offerings. So more to come. At this point, I will hand it over to Molly.
Great, thanks so much, and thanks for having us here today. I thought that I would kick us off by just giving a little bit of an introduction to Stop the Spread for those who haven't heard about us before. Michelle, you can go to the first slide, please. Thanks. So just a little bit of background on us. And I'm not sure, Michelle, if it's gone back to the previous slide, but I'm happy to keep going and and can speak over. Do you want to make sure that the slides are working?
I'm on the first slide out of your deck.
Can you go to the next slide, please?
Sure.
Great, thank you. So just a little bit about Stop the Spread. As the name might suggest, we were stood up in March 2020 as an organization to respond to the pandemic, at the time really absent a national response. We started out very much as a matchmaking organization on the supply side, bringing private sector partners together to produce ventilators and PPE to respond to testing. And as we saw the needs of the pandemic continue to evolve, so did our work. And we moved from the supply side into a focus on the demand side, specifically communities that had been really hard hit by COVID, where they were in need of additional resources in their response. And on the next slide, you'll see how we started to actually do this work. We brought partners together to do a couple of things. One is capacity building around COVID response resources. We have over 650 partners that we have worked with across the lifetime of our organization, and then started to take what we call a hyper-local approach, really working with trusted community partners, safety net healthcare providers, to make sure that those supplies were meeting the needs of the communities that needed them most. As a part of that evolution of our work, in addition to the technical experts that we were already working with and epidemiologists, we also started to bring on leaders from community-based organizations as a part of our advisory committee. The other thing we seek to continue to do in our work, and today we're going to dive into what this actually looks like on the ground in our work with Community Healthcare Network here in New York. But we also continue as a national organization to try to amplify the needs of the communities that we are serving and raise attention and use our platform to be able to raise awareness of the issues that communities are facing right now in response to the pandemic. If you go to the next slide. And if my audio is a little bit glitchy, I just saw a note in the chat. I can actually just pause my video and maybe that will help a little bit with the bandwidth. So the work that we do is truly through a partnership approach. We believe that by bringing partners together, we can collectively impact the needs of communities and serve them more effectively. So we have worked with organizations ranging from healthcare partners, as you'll see on the left-hand side, CHN here in New York, as well as Charles B. Wang. We're doing some work in Chicago currently, as well as out in LA on the West Coast with an FQHC called St. John's. And across that work, we've also started to build relationships with community partners who are trusted partners in the communities that we are serving. We think really critical to this work as well as the opportunity to build public-private partnerships. A lot of our work has been funded through google.org. And we also work with organizations like MPulse and Consejo Sano around communication and messaging to patients, different scheduling platforms, as well as different organizations that can help to address the needs beyond vaccines that many of our community members face, like Unite Us. We also work with national organizations like the C19 Coalition, where we have launched what we call a Sunday Supper approach to vaccines, really creating a community experience. We're going to talk a little bit more about what that looks like later. But we know there are a lot of great organizations out there that are doing meaningful work right now. And so we seek to partner with them to not try to reinvent the wheel and to do this work more effectively and scale. On the next slide, I just wanted to, before we jump into talking about the specific models, which David is going to speak to, just wanted to talk about how we think about bringing these partners together in the context of vaccine equity. So there are three tenets to our work focused around access, awareness, and trust. Access, which David's going to talk a lot about in the way that we've stood up these models to create access in trusted spaces, whether that is a church, a supportive housing unit. We seek to bring vaccines to the community, ensure that they have access in a comfortable and safe space. We also seek to leverage trusted relationships, trusted partners that already exist in that community as a way to increase awareness about the vaccines themselves, their safety, build vaccine confidence, build awareness about where the sites currently exist and how to access them. But we also think that this is, there's an opportunity for trust building when we think about our Vaccine Plus model, which is really about not only providing vaccines, but also addressing the additional healthcare or social needs that community members may have. All of this work that we think of as a flywheel for vaccine equity is powered by our partners. So powered by anchor healthcare organizations that are deeply embedded in the community, as well as community and faith-based organizations, and our private and philanthropic sector partners as well. And on the next slide, the last point I wanted to make before we jump into the models, we really see this as an opportunity to not only get shots in arms, but also address those additional needs of community members that have been exacerbated during this time. We call this model Vaccine Plus. Emma's going to give you some examples of what it looks like. But the idea is effectively taking that monitoring period after someone is vaccinated and using it as an opportunity to connect individuals to other needs that they may have in that time. So with that, I'm going to hand it over to David to talk about Community Healthcare Network and to talk about what some of this work looks like on the ground.
Thanks, Molly. So I'll tell you what I'm planning to do is, so I'm going to walk you through basically CHN's history for the past 6 months, trying to get vaccines out into different communities. I'll go pretty quickly through our models, and what I want to highlight is the way we've really leaned on community-based organizations, faith-based organizations to make it successful. But I'm going to be covering a lot really quickly, so obviously if people have questions, I'm happy to answer them and give more details. But I just want you to see both how fast the situation's been moving and how each phase of the work we've done really looked to different types of community partners to support us. So go next slide. So the other thing I'm going to point out, you'll see this is a partnership with lots of people, right? So we're a community healthcare network. We're a federally qualified health center. If you don't know what that is, it's basically outpatient primary care, generally in underserved communities. We have 14 sites across the 4 boroughs. So we're the healthcare leg of this. But then you had Stop the Spread, which has been helping me from day one to do this in all these different communities. Staffing, while Cornell was early on offering to staff, use their medical school, they brought along Hunter Nursing School as well. We then brought in NYU, LIU, so huge numbers of people coming externally just to help us because we, frankly, don't have the clinical staff to do it. The city and the state and the Fund for Public Health, frankly, have been critical in, well, the city and the Fund for Public Health and just making sure we had resources to do it. None of this is reimbursed, right? This is not a money-making venture for us. They basically offered to cover our costs, and we said, okay, then we'll incur the costs and get the vaccines out there. And then the state, a lot of what we did relied on the flexibility the state gave during the time of COVID. It's actually a slide that's not here is how crazy the next few weeks are going to be now that the emergency orders are gone, because suddenly all of our staffing plans and a lot of what we do changes, but that's a different webinar. Okay, next slide. Okay, just quickly, this is CHN, right? We're doing outpatient care all over the city. I'll just say, just because it informs the model one, what would basically look like you come into one of our sites, figure 5,000 to 9,000 square feet, anywhere from 6 to 12 exam rooms, small waiting areas. That's how we practice medicine here. Okay, next slide. So I'll skip this. Let's just go right to the models. So the first thing we tried to do, right, so day one happened. We were given vaccine. This was in late December because we were one of the early organizations that got access to vaccine from the state. Yet we're also told, by the way, you can't. Your patients don't qualify, right? Our patients are mostly Medicaid, so they're younger. They have lots of co-occurring conditions, but that wasn't the group of people that was eligible, right? The people that were eligible were either essential workers, and soon it opened up to the elderly, but it was just effectively essential workers. So we vaccinated our staff, but we had a lot more vaccine than that. And suddenly all of these community-based organizations, basically nonprofits, also have essential workers on their staff. And the state was telling them, oh, go call FQHCs and they'll give you vaccine and they'll vaccinate your staff. So it was pretty wild because we didn't know that was happening until we started getting all these phone calls. And what we tried to do, the first model we said is, all right, let's figure out a way to bring the staffers of all of these nonprofits to our sites. We'll do it a Saturday if we have to, do it after hours, and we'll give them vaccine there. And we tried that, and it was really, really hard to do, mostly because COVID was new for everybody, frankly, with the need for social distancing, right? You couldn't just bring people in the door the way you would normally bring somebody in for a flu shot. You had to bring them in. They had to be observed 15 minutes, and they needed social distancing between them. And frankly, none of our sites were set up to do that. We just don't have the physical space. So we tried several times doing in our sites vaccine events. We did it for nonprofits. We did it for several supportive housing providers where they could bring their residents too. So those people were also very early on eligible. We were very excited to have the opportunity to do that, but it didn't work. It wasn't efficient. We had lots of staff trying to navigate narrow hallways, people spilling out into hallways. So that was our first model, which didn't really succeed, but it was our first effort at this. Next slide. So model 2, in the end of the day, was we went to several of these same nonprofits, especially housing providers, who have clinicians on their staff, generally nurses, sometimes physicians and psychiatrists, who didn't have access to vaccine because they're regulated differently than we are. And we came up with a legal way to give them our vaccine. So basically on a given day, we would speak to one of them. We'd say, so breaking ground, they're on this page, right? They're a large supporting housing provider in the city. They have a relationship with NYAM Medical Group, which is a nonprofit doctor office that basically works in there. NYAM has doctors. They know how to give vaccinations. They don't have access to vaccine. We reached a legal way to basically take our vaccine and give it to them. And then they could go and run their own events at their sites. And this was huge for us because it let us, first, got away from the issue of our own sites not being suitable for this work. Second, it let us go to places where people, especially some of the housing, they weren't going to come to our site. We did one, right? We saw large no-shows. You really got to go where people are to do it. And it helped us immensely with staffing, right? We have a lot of clinicians on our staff, nursing and doctors, but they all have full-time jobs. And frankly, there's no money in any of this. So anything we do, and we do overtime, we did a lot of overtime, but there was no reimbursement for any of it. And we're just trying to find ways to make this something that we can keep doing without burning out our staff or burning out our organization. And it was great. We did a lot of this in February and March. I see the numbers. We did 13, 6 CBOs. It wasn't huge volumes, right? These weren't hundreds and hundreds of people getting vaccinated, but it was people in supportive housing. It was people who are enrolled in ACT programs, so they obviously need a lot of other support. We had Janie actually go and do street medicine, bringing vaccine to one of their street clinics and giving it to 10 people there. So the numbers were low, but this was definitely populations that we don't deal with day to day. We had no idea how we personally would get there, but through our partners, we're able to go and really meet people where they were. Okay, next slide. So model 3, community-based pop-up. This was kind of a growth from the model 2. And what we started doing here is we started reaching out as more and more eligibility was opening up. We're getting more and more phone calls for larger events. So we had some relationships, especially with First Presbyterian Church in Jamaica and Queen's Defender. And we said, what if we just come to you on a weekend and you all go to your communities, whatever your community looks like, and bring them all in the door? We'll be there. We'll give you the clinicians. We'll provide some administrative support, and we'll run an event. And we started doing those, and they were incredible. So early on, we were doing events. We were getting between 300 to 400 unique people coming for first doses. So it's a huge amount of pent-up demand, and you were doing it within the context of a community, like the St. David Episcopal Church. I think we were there 4 times. Every time they would get different members of their community in the door to do this. Same with First Presbyterian, and there's a longer list of all the people we've done that with. I think, great, at this point, we've 19 pop-up sites, right? We've done over, a little around 3,000 first doses. We're still getting through the second doses now. Great numbers. It still is actually what we're very interested in doing. I think the challenge today is there's still a lot of community-based organizations and faith-based organizations that want to do these events. They think it's very important for them to do it. What I think we're seeing is it's much harder to get people in the door. So we're finding that a lot of the organizations that want to run the events actually don't have real sense of their community, who they're able to get into the door. And we've we've had some, I'll call them misses, meaning our expectation didn't match. One church, I remember we went out there, we were very excited. They'd been closed. They were opening up after being closed down for many, many months. Their pastor was very involved. And in terms of recruiting people in the community, we expected between 100 and 150. I think we got 25 people in the door. So there's this mismatch between, I think, what some of the leaders think the demand is and what it is. And that's just something we're navigating now, because it's very challenging to staff up for a 150 person event, have 25 people show up. But we're trying to remeasure what success looks like. But there's a model that has been going pretty strong, and we'd like to keep doing it. And then you go to the next slide. Oh, so I see a quick question. I'll just answer it about the difference between Model 2 and Model 3. So Model 2 was literally, we took our vaccine and gave it to somebody else, and then they ran their own event. So I would be much more careful if this was early on and it was done legally, very careful legal arrangements between us and them. But it was basically us saying, you can do this yourself, here, go ahead. Model 3 was going to places like churches that, like, these are not medical places, these are just community-based organizations. And we said, you go, you recruit everybody you can for an event, we will come and we will staff that event. We'll help with marketing, we'll help with all this, but like, you're the connection point to the community, you have to bring them in the door. So the fourth model is also something we started. This actually started only 3 months ago in April, is with a partnership with the city. We opened up 4 new sites solely for providing vaccines. We did in 4 different communities. They were communities that the city had asked us to target: Washington Heights, Harlem, East New York and Brooklyn, and South Jamaica and Queens. And they basically asked us to do it, and they effectively gave us the green light, and everything else was for us and stop the spread to figure out. We cold called, we found church partners, we set up 4 sites in 4 different churches in these communities, and we've run them 4 days a week for the past 4 months. The results, as you can see, were over 20,000 doses administered. I think that probably by today we have over 11,000 unique people who got vaccinated at the sites. So we think it's been a huge success. We've had tons of partners: Cornell, NYU, LIU, the Black Nurses Association of the Greater New York City chapter has provided staffing. So it's been pulling together lots of different pieces to run these sites for fast 3 months. Okay, next slide. Great, and this is just a little bit more of where these 4 sites are in the churches. And I think, yeah, if you just go back, I thought what was just really great about this is, you know, I think we always knew intuitively that by going to the churches, we're going to places where people hopefully are comfortable going versus maybe, I don't know, one of our medical offices. And when we did a survey, we got results like this, where people saying that they felt safe at the site. We saw data, I think at all 4 of our sites, over 85% of the people we surveyed said that the service was either excellent or great. And you were able to do this because you were able to do it in a small space. Oh, we hired all of the church staff to do all the administrative work there. So you really brought community people in, and they were invested in making it a success because they were working there as well. So we thought that was a great model. Next. And just to show you a little bit of data, this is data from the 4 sites, and just the percentage, right? 68% of the people who got vaccinated there were Black or Hispanic. And we know our goal was to target, obviously, communities where the vaccine rates were lower. I will say my hypothesis, I don't have the final data, is for the pop-up work we did, right? When we were going into these churches, the numbers are actually even higher, but we just got back our first cut of data yesterday. So I don't know what the numbers actually look like, but it was similar or not more. Okay, next slide. Right, and where are we today? So Model 5. So I'd say the first 2 models, right? The first model in our sites, we'll do some at this point, but that's not the major focus. The second model, giving our vaccine, we would keep doing that, but I think the need just isn't there. Then we've been in touch with lots of nonprofits. They've gotten the access that they've needed for their people who are interested in being vaccinated, so they're not asking for that anymore. The third model, the pop-ups, we keep doing. The city's encouraging us to do it. It's just slowing down. There was a time we were doing roughly 5 a weekend. It's slowing down quite a bit because we could be doing 5 a weekend, but the numbers just aren't there. So it has to be a lot more thoughtful as to where we go and how we plan each event. And the fourth model, which is the sites, we're actually going to start winding them down next week. The numbers, we put a lot of money into marketing and trying to publicize them in their communities. We've done that. The demand for that type of service just seems to be petering off. So after conversations with the city, we're going to start closing those as well. The next model, which we're still developing, we haven't done it, but we have an opportunity to do it in 2 weekends, is it's like a pop-up, but instead of us trying to create a pop-up with our community partners, we look around and we find what events are already happening in this city, and can we go with, I'm not sure, 2 people, 3 people, a suitcase that's refrigerated, that's got vaccine, and go and offer the vaccine there. And it would be a whole new type of experience for the vaccinator. It would have to have a big outreach component too, right? Because people aren't going to be going to these events expecting to be vaccinated. But we think it's the opportunity now, because honestly, we're not sure otherwise how we keep going and finding people who haven't been vaccinated and figure out a way to get them vaccinated. So that's what we're going to be trying next. Is there any more slides? I think that's the end of my piece.
Awesome. Thanks so much, David. And I can pick it up from here. My name's Emma, and I'm excited to talk with you more about the Vaccine Plus model that Molly hinted at the start, and that I think is really relevant to our work to continue to bring folks in to get vaccines if they haven't already. Next slide, please, Michelle. Awesome. Thanks so much. So to give an overview, Vaccine Plus is a model that aims to address community member needs and make connections to healthcare and social services in the vaccination setting, and more specifically in that observation window. I think what we've realized is we're presented with a unique and really important opportunity. Folks that have perhaps been disconnected from care for a long time and have almost certainly been disconnected across this year of pandemic are now re-entering a healthcare setting to get vaccines. And the question is, how can we kind of leverage that moment to create a really positive experience? And I think we see this as a chance to both address basic needs kind of in the immediate, but also to build trust in a healthcare system in like a really particularly critical time. So working to first understand the needs of the community, then bring in services and care through partnerships to that site of vaccination is kind of this new phase of vaccine work that we've been up to recently. Next slide, please, Michelle. I'll give a little bit of an overview. My day-to-day is largely invested in overseeing the Vaccine Plus work that we're doing in New York. So I'll give an overview there and then go into some more specifics as well. But I think the way we started this work in New York was with a needs assessment across those 4 fixed sites that David just described for us. The goal was to determine what are the needs of the population as they would state them themselves. Because I think part of the value of this model is providing targeted interventions that are community informed and driven. It's not a Band-Aid solution, but one that is much more tailored and modular in that way. So in addition to enumerated needs that we saw, a lot of folks struggling with stress and anxiety, COVID-related needs about learning how to stay safe, and then healthy eating, just learning more about nutrition was a third one that was listed. And in addition to those enumerated needs, we saw that a significant amount of folks coming into the sites did not have a regular doctor providing care, and were also uninsured. So I think from the beginning, we were really thinking about how to kind of create a wrapped model that would allow referrals and allow care, even in the absence of some of those kind of structural pieces being in place. So looking at the resources that we had access to and kind of focusing on what we could stand up quickly, we started with a partnership we had that both David and Molly mentioned with Cornell Medical School. And they have an existing program that brings health screenings to community settings in a pop-up way. So what we started with, and the way this looks like, is the Cornell team is able to administer brief health screenings at the point of vaccination or shortly thereafter. And this is in the form of a finger prick that is going to test for cholesterol and also for diabetes. Those results come back within 10 minutes. So all within that, again, kind of confined 15-minute observation period. And those results can be delivered by team members at that point as well. And what we've compiled is an integrated program in response to needs that are being expressed. We pulled off small pilot to start out at one of the pop-up sites. We learned almost 75% of folks were Spanish speaking primarily, and almost all of the folks in that group did not have access to insurance. So we realized that being able to really ensure that these services were covered was key to kind of the stickiness of this. So in partnership with Community Healthcare Network and also Public Health Solutions, bringing in the community healthcare worker perspective, we've been able to create a program that we can refer folks that are screened as pre-diabetic or diabetic to. This includes nutrition sessions from CHN, insurance enrollment, connection to primary care, and also food services and access. We think all of these pieces are super intertwined, as this audience I'm sure is fully aware. So being able to kind of catch all of them together and address them in a multi-pronged approach is what we're targeting. I think what we've seen is this is also a really interesting entry point in offering a health screening. You're not necessarily starting a conversation about underlying needs of connection to a regular provider or connection to insurance. Even food insecurity is not necessarily the first item on folks' mind when they're engaging. But again, this opportunity to engage in the screening opens the door to kind of a broader understanding of all of that. Next slide, please, Michelle. Thanks so much. And I think that kind of what I just described with the health screenings, a key learning from that is that folks are interested sort of independently in these additional added services. We, in our second screening event, were able to advertise a health booth as being part of a Juneteenth celebration at one of our sites. And even people that had already been vaccinated kind of presented for the screening, which informed a little bit of our design of this next piece that I'm about to share with you all. So kind of hot off the presses just last weekend, we were able to come together with the community in Corona Queens for a Pride celebration and also to bring vaccines. It was also HIV testing day, National Observation on the Sunday, the 27th. And so that was a part of kind of the Vaccine Plus components that we were bringing to the table at this event. That's something that we advertised in advance, so folks were aware that they could not only get tested for HIV at this event, but also be connected to PrEP if needed. So I think our vaccine numbers, as we've been talking about, it's tougher to get those vaccines, so a little bit lower than we hoped, but a really cool finding. We had 21 folks who came in specifically for an HIV testing and 18 people who are connected to PrEP. And I think the really kind of cool piece here, in addition, I mean, this was a day of celebration. We had a taco truck, folks were getting meal passes if they got vaccinated and brought their families. It was all around a really kind of community-oriented event. But in that setting, we were also able to kind of open up conversations into, what are some maybe misunderstandings about the vaccine? Why are folks here for a test, but not to get vaccinated if they haven't already? How can we kind of move them a little bit closer towards making that decision? And I think what we're kind of learning throughout all of this, this Vaccine Plus component, this additional piece, what started as I guess the idea began as something that we could do in the intervention space while folks were there for that vaccine. I think we're evolving and learning that in and of itself, folks have an appetite for addressing health issues right now. I think people it's at the front of their minds to take care of themselves in a way that maybe it hasn't been before. And there also hasn't been a lot of opportunities last year. So this kind of Vaccine Plus approach not only kind of builds trust, people could get an HIV test without getting their vaccine. That wasn't really the point to be exclusionary, but it also presents an entry point and a evolving conversation around vaccines. It can be a draw and not just kind of an added benefit. Next slide, please, Michelle. Thank you. Awesome. So I think this is a pretty New York-centric group on the line, but I figured I would diversify geographically a bit and share some of the really exciting work that other folks on our team are doing on the West Coast. This will give a little bit of geographic diversity, but it's also a little bit of a different flavor of the model that I think is kind of interesting to discuss. So On the West Coast in LA, Stop the Spread has partnered with St. John's Well Child and Family Center. St. John's is the largest healthcare provider in South and Central LA, and they serve patients across all ages through a suite of healthcare and social services, as well as community outreach and education programs. And through our partnership, St. John's has embedded Vaccine Plus services across 9 of their clinics that are distributing vaccines. Yes, and like I mentioned, this looks a little bit different. So embedded in each of those sites, we currently have an on-site trained outreach worker, and they're in that observation space, administering a quick needs assessment that asks folks to list their priority need across a couple of different areas. So similar to what we kind of conducted before, building some structures in New York, but this is happening really individualized and on the spot on the LA side. And I think it's a really kind of unique screener, I suppose, because there aren't eligibility requirements for the next step. We're really just asking folks what they need and then making a connection to get that need addressed. So people coming in for a vaccine kind of walk away with the next step across a number of different domains. After outreach workers connect with individuals in the observation space, participants receive a follow-up message via their preferred form of communication. So this might be a call directly from the St. John's Benefits Counseling team, or a communication from one of our partners, Consejo Sano, their patient engagement platform that will outreach via SMS to learn more about the specific need that perhaps individuals didn't feel comfortable disclosing in full, kind of in that observation space. And then following that, the Vaccine Plus team at large, including folks from Consejo Sano, leverage the Unitas platform and network in order to submit referrals and then close the loop on those referrals. And this might be to community-based organizations, but may also be to one of our additional kind of private partnerships as well. I think one that we're really excited about and kind of breaking for this, the numbers have changed since we finalized these slides, but we have a partnership with Bento, the second number here, in their platform that uses text messaging to connect folks with convenient, nutritious, and prepaid meals from local restaurants. So families place their order and they pick up their meals directly from the restaurant. And this is like free meals for individuals and also their households, kind of across a number of weeks as needed. And we've broken 1,000 meal referrals and are thinking about a similar model in New York as well. But really exciting, and I think the kind of ability to Molly's point before, the power of bringing in organizations like Bento to fill some of these holes in a slightly non-traditional way has been really helpful for users as well. I think, again, adds to that really positive experience and a kind of ongoing restoration of trust in the system at large. I can pause there, but I'll give Molly a chance to add anything additional before we go to the next slide. Or next slide's fine.
No, that's a great description, Emma. And I do think that the partnership with Bento as a really interesting private sector partner to address food needs in the community has been a very seamless experience for the individuals that they are serving. And we've just had incredible uptake in that service in particular, and have sort of continued to iterate on the model around the things that people are getting excited about in the vaccine space. And I think Bento has just been a particularly phenomenal partner to work with. On the next slide, and I'm going to keep my video off just to help with the bandwidth a little bit. So apologies for that. I wanted to talk about one other take on Vaccine Plus, which is this idea of Sunday Supper. This is a partnership that we started with a group called the C19 Coalition. They are a national COVID response organization. And we launched the first Sunday Supper in New York with Community Healthcare Network and the Church of God in East New York to really create a community experience. This was on Mother's Day. The idea was to come in and get a shot for you and your mom and to go home with a meal from a local neighborhood restaurant. I think we ended up distributing around 500 meals. So really nice way to invest back into a neighborhood community restaurant. This is a Caribbean restaurant in East New York. But people also just had a really positive experience across the day. And we think that spreading the news about vaccine sites and their safety through word of mouth and personal networks is really critical in creating these positive community experiences like a Sunday supper or the Pride event that Emma talked about, helps to spread the word to the communities that we're trying to reach. We also, David mentioned the partnership with the Greater New York City Black Nurses Association. We also partnered with them on this day. Dr. Brittany Richards was on site solely to answer questions about the vaccine that people had. There was a gentleman who would not get vaccinated until he spoke with her, and she walked him in personally to the church to get vaccinated. And then he also went home with a meal for himself and then a meal for a friend or a family member that day as well. So we just wanted to share some of these examples of the community experiences that we've been building. And as Emma mentioned, they are all very much meant to be designed and tailored based on what we think will be most impactful and meaningful for that particular community. And so with that, I would love, before we jump into Q&A, to show everyone a playbook that we've been creating at Stop the Spread for how you can take these ideas and implement them locally in your communities. I will pull this up on my screen just to show everyone what this actually looks like. So Emma can drop the link to this into the chat, but this is an open source playbook we have developed. It has very much been informed by our work with David and the team at Community Healthcare Network, as well as our partners out in LA. It is intentionally meant to be a very user-friendly, downloadable toolkit that can be applied with lots of features like PowerPoints and Excel tools and Word documents that you can download and edit and adapt for the vaccine distribution strategy that you are trying to deploy. We know there are a lot of playbooks out there that are 100 pages of PDFs. We did not want to create that in this instance. And so I'll just give you a little bit of a quick tour. Inside of the playbook, you will see information on the critical role of safety net providers like FQHCs, who have just been so integral to the country's response to the pandemic, as well as community and faith-based partners. I think this group knows this very well. But there is some interesting data in here as well, if it is helpful, as you think about partnering with other organizations in your vaccine distribution models. We also have a section on cross-sector partnerships that speaks to the different stakeholder roles and responsibilities and the various types of needs where we have seen partners either augment services that may already exist or fill critical gaps. David talked a lot about these, for example, on the staffing side, where we partnered with organizations like Cornell to augment the clinical staff that CHN already had. You'll see information in here on using data and partners that we think are doing particularly interesting work to help identify where there is a real need at the moment for continued focus on vaccine distribution. Some of these partners will also highlight not only COVID risk, but other risk factors, social risk factors in the communities as well, if that is helpful in thinking about something like a vaccine plus model or just barriers to access right now. We've also included information on the different types of sites that you can think about for where to stand up a community-based vaccination site. And at the bottom, we've included examples of partners that we've worked with and what this work actually looks like, as David spoke about the work with Church of God in East New York earlier. A couple of other things I just wanted to point out. So David talked about various pop-up models, as well as the sort of fixed models where we were in churches for a period of time. Inside of the toolkit, you will find partner discussion guides for having those conversations. Hopefully you can see on my screen a PowerPoint that we've created. You can download this to think about what this would actually look like in working together or facilitate a conversation around partnership. We've included lots of different tools for site directors These were actually used in our work in New York. Things like a checklist for pre and post day clinics, if you were to run a vaccine site. So again, really trying to make this very user-friendly, very as easy as possible to replicate these models in your local communities. And the one other thing I wanted to mention, because we really didn't get into it today, but it's so critical to the work, and you'll see this in here as a sort of coming soon section of our playbook. We've been doing what we call a drop. We didn't want to wait until we had a final finished product. We wanted to continue to push the information out because people need it today. But we are about to do another drop that will focus specifically on community engagement and outreach, including ideas around on the ground, sort of how to have conversations, how to leverage networks that already exist in the community and partner with CBOs to build vaccine confidence or awareness, going back to that flywheel model. It includes a section on combating misinformation and building vaccine confidence as well, that is full of really great resources that already exist. We've broken them down by different types of communities, as well as different types of questions that are coming up commonly. And we also talk a little bit about some of the digital tools that we've had experience with as well. We mentioned Consejo Sanyo, MPulse. These are technology partners who can also be a part of that way of sort of scaling outreach through a technology solution. So I just wanted to highlight that that section is coming soon, because I think more and more we're seeing that's where a lot of our work is focused. We've stood up in New York what we call a refer a friend model, where we aren't actually incentivizing people to get vaccinated. We're incentivizing people to find their friends and bring them in to get vaccinated. And we will include information on how to do that if you'd like to do that model. And we're also really starting to think about that with sort of youth and back to school and getting kids vaccinated before schools open back up in the fall. So lots of great examples. And you're welcome to explore the playbook. We welcome feedback, or if there are great ideas that you're seeing that should be featured as well, we would welcome those too. And also happy in follow up to this to jump on a phone and talk through pieces of this as well, if that would be helpful for folks. So I'll hand it back over to you, Michelle.
Great. So I think we'll move into the question and answer portion. So if folks have questions, you can enter them in the Q&A box. We could maybe start with the first question that's come up. Did you make special effort to include people with disability? Anyone who wants to take that?
So I'll take that. If we're talking physical disability, all of the sites were ADA accessible. That was part of the initial review that we did. So, and I know just personally, like I saw wheelchairs and like the other rolling devices at probably each one of our sites. If you're asking about kind of like, do we do specific outreach to communities that serve people with disabilities? We did with some of our community-based organizations who happen to have that, but I'm thinking that, for example, for the 4 permanent sites, I'm not sure. We reached out to a lot of nonprofits, but I don't think we did a targeted outreach specifically looking to bring in people with disabilities. For things, we had iPads at all the sites that could do both translation and sign language. So I'm not sure. We tried to accommodate as much as we could. If there's something specific you're looking that maybe I didn't address, just add it in the question.
So in the absence of any other questions right now, I wanted to raise a question for the panelists, something that came up with our community-based partners on our steering committee around, this effort to get trusted partners, community-based, faith-based organizations involved in distribution of the vaccine and other areas related to the vaccine. There was concern that the CBOs are already kind of strapped, and like where the resources for this, for obviously there is work on the part of community-based organizations in implementing these models. And so I wanted to ask the panelists if they could speak at all to any funding or ways of the CBOs generating revenue from this work. But first, I did also want to share one potential funding opportunity with the audience, which is that I believe about a week ago, New York City announced a new program called the New York City Vaccine Referral Bonus Program. And I'm going to ask Hannah to put the link into the chat. So now civic groups, faith groups, tenant organizations, a whole range of different types of organizations can, if they sign up through the link that she's gonna may have already put in the chat, can receive $100 per person if they, write the organization down as having referred them to receiving the vaccine. And that's up to $20,000 that an individual organization can receive. So that is a potential source. But any other ideas that panelists can share around that topic?
I can, I'm sure David, you have thoughts too on this. I think, yes, that is a challenge, right? Like funding has been is a challenge for any organization that is trying to run their normal operations and then also do this. We have tried as much as possible to put funding back into the communities. David mentioned in the churches, we hired their staff to do administrative work. At the Pride event that Emma mentioned, we had a Zumba instructor from the community who brought his whole class to our event, as well as a taco truck that was from a single mom in the community, as a way to sort of, get her a little bit of attention for the day and marketing, and also just put some funding into her business. And so we have tried to do that as much as possible. I think the other piece, we've also tried to just sort of leverage, when we think about communication, for example, leverage channels that already exist, not necessarily asking to do anything new, but working through existing channels and trying to make it as easy as possible to communicate and spread the word about the sites. David, I'm sure you have thoughts here too, but those are mine.
Yep, I'll ditto that. I mean, the other thing we did early on is we made sure that our budget included rent to pay all of the churches that hosted us. So again, that was another way to get money to them. One of the things, just building off what Molly did, is, so I don't know if you all are familiar with the city's VAX system, but in short, it's the system which is the vaccine registration system, which we had to use, and it's pretty terrible. And there was this great way where they were telling us you can go and you can allow all these community-based organizations to get backdoor access as administrator and to prioritize getting their community members in, which was great in theory, but I think just like you were saying, it ended up being a lot of work for the community-based organizations, and they couldn't do it. So we actually, working with Stop the Spread, found a different software, created a whole new mirror scheduling system, got a staff to do data entry between the two software systems until we built a bot that would kind of automate this transfer. So I think the way we've thought about it is we had opportunities to get money to the CBOs, we did. Where there were opportunities to make life easier for the CBOs, we did it too. But I want to acknowledge that it was a point in tension. I mean, some of the pop-ups, very frankly, there are certain organizations that we did pop-ups with that asked to stop doing pop-ups with us. They were one-day events, but they actually want us to pay rent. And we tried to explain there is no budget, right? We're already using our resources for this, and that was challenging for them. So I think that's a real tension point that I don't think we've solved, but we tried to find opportunities to get the money where we could.
Thanks so much. So we have about 5 minutes left. And there are 3 questions in the Q&A box. So maybe we can do 1 minute for each question. So the first question is, are there programs and partnerships you think you will maintain for future health emergencies? Are there any that you couldn't implement now that you want to be put in place for the future?
I think it's a really good question. I'm going to completely punt on. I think that what I've loved about this whole program was there was a really good reason to work closely with these people towards the same objective. And I think we all worked really well together, us and the churches and the medical and nursing schools. We were all very aligned with a very clear goal. And I think we're all walking away from this going, that was an incredible partnership. What do we do next? I'm not sure yet how you take that feeling and keep running with it in a world where the goals aren't as clear, the funding to get something done aren't as clear either. So the answer is, would love to, and we've actually started having these conversations, but I'm not sure how it's going to play out because I don't know what we're partnering around just yet.
Got it.
I will add, I know, Michelle, you want to keep it to 1 minute per question. It's such a good question. I will just add that we were on a call this morning with one of the deans at Cornell, and just hearing her speak about the experience that the med students have had working with Community Healthcare Network and working to administer vaccines in very historically underserved communities. She thought that this was, career defining in a way, and that they were energized. It's impacted the way that they're thinking about their future work. Similarly, with this youth ambassador program that we are getting started, we hope that that will influence young adults to think about either community organizing or careers in healthcare. So I think there are some long-term impact for sure.
Great, thank you. So the next question is probably something a number of attendees are wondering about, which is someone who's interested in adding the Plus services to a site they're supporting, and who can they reach out to for support around this?
Yeah, folks are welcome to reach out to me. If that would be helpful, we could start a conversation or a brainstorm. Certainly there are tools in the playbook, but my email was on a previous slide. It's emma.smith@stopthespread.org. You can put it in there. But yeah, we'd be happy to chat and direct in any way that we can.
Thanks, Emma. And then I think we'll answer one. We'll see how quick the answer is. So another question was, what were the ages of your population? How did you approach individuals who did not want to be vaccinated? So a little bit more around, maybe sharing more around the conversations and the misinformation trust piece.
Yeah, so I'll talk quickly. So from the age perspective, it was everybody. As the age expanded, we were open for anybody. We've been doing 12 and up. Every age group had its own challenges in terms of consent and all that, but we've been open to anybody as long as, obviously, some people couldn't get to our sites. Whoever got to our sites, we vaccinated. In terms of speaking to people, so at the sites that we ran that were the permanent sites, people who were coming in the door already wanted to get vaccinated. So we weren't really having too many conversations with unvaccinated people. At our pop-ups, we were, and I would say we tried lots of strategies, and I'm not sure which was the most effective, but we tried a lot. We brought, for example, nurses from the Black Nurses Association specifically to be involved in kind of community outreach, not to vaccinate. The theory being that people would want us to talk to clinicians about this. The team at CHN that we used a lot on the weekends are people who already do outreach for lots of other programs around HIV and PrEP. So they're kind of already engaged, and what they do day to day is speak to people about these topics and try to get them thinking about their health. So that's a kind of a vague way to say we tried lots of ways of getting different people to speak to the people who might be vaccine hesitant. And I don't have a way to quantify how successful it was or wasn't.
Thanks.
It was a moving very fast.
At our Pride event, there was a gentleman who I think brought, Emma, was it five people over to get vaccinated from the park that day. So also just, again, like going back to personal networks and how powerful that can be, I think has been really effective. And we're hoping the Refer a Friend program can help to add a little bit of structure around that as well.
Thank you. So I think we're gonna start to wrap it up. So I want to thank all of our wonderful panelists today, and thank everyone for attending. Please, if everyone could take a few minutes to fill out our evaluation survey, that'll really help us. And Kana's gonna put the link in the chat as well. That'll really help us design and improve our TA offerings with your needs in mind. And we'll also have a link in the follow-up email as well. So thank you everyone again, and have a great evening.